bradycardia, mental status, and a history indicative of them maybe being hypothermic, right? We'll see that's important, especially if you get into later stages of hypothermia. Why are they hypothermic? There's 4 different stages. By stage 2, there's already some altered mental status. They may not even be shivering. By stage 4, pretty severe hypothermia, and they may not even have, they don't have any vital signs. Okay, this is why the history is important, because what else would cause cooling of the body and have some vital signs?
Absolutely.
Right, there's no vital signs, the body's cool. So how do you know if this is hypothermia versus we need to declare death, unfortunately, right? So some of the history is important to factor into that. It's not an easy decision to make. So because it can cause pretty massive polysystemic concerns when you want to get CBCs or electrolytes, we get basically the whole gamut. Blood gas studies, coags, glucose, creatinine. See if there's any pulmonary edema, especially for post-water submergence. And then the treatment is based on how much hypothermia there is, but really the idea is to raise the temperature, treat any possible airway or cardiac arrest. So get the wet clothing off, get them rewarmed, cover them with blankets if necessary, get some warming, lights, thermal mattresses. Sometimes you can even, IV fluids might be helpful. Warm, humidified oxygen, bath, try to get their body. So moving into the other side, any questions? Into the other side of the picture. Heat illness. So heat illness is a pretty broad spectrum. And it can go all the way from heat cramps to what we call heat stroke. Again, it's fairly important. They have a fairly good history about why they are having this, right? Someone coming in hyperthermic with a high body temperature, can't always assume it's because they've been out in the sun too long. So heat cramps, their core body temperature is fairly normal, maybe a little elevated. Rarely will they have electrolyte disturbance, but they're going to have cramping, brief severe cramps of skeletal abdominal exertion. The next level up, though, is heat exhaustion. So there's more or less constitutional symptoms involved here after heat exposure, weakness, fatigue, headache. This is the type that you most likely will see coming into the emergency room. Sweating, they might have different degrees of sodium or water depletion. So you want to monitor the core body temperature. Heat stroke, though, is a life-threatening failure of thermoregulation. Their rectal temp may be at 105.1. There might be some associated neurological dysfunction. There might be vomiting, shivering, coma, even seizures. Might be posturing, indicating some neurological damage. And it may involve right. So in other words, once you have a central nervous system dysfunction, you have to worry you're dealing with stroke. But that itself is since there's that altered mental status, you're going to be possibly incoherent, may even be combative. And you have to worry about global derangements such as renal failure, rhabdo, myocardial necrosis, maybe even DIC or ARDS. We have those 3. We have heat cramps and heat exhaustion. The heat cramps is fairly easy. Rest, rehydration, maybe electrolyte solution, not even necessarily a Gatorade. If it's fairly severe cramping or heat exhaustion, then you might need some IV fluid rehydration. You're going to tailor that based on what their electrolytes look like. If they're hypotensive, then you might need to give them IV fluids. Active cooling like fans, missing cold water, put some ice in their neck, or so that basically gets them down to 38 degrees to get there, and you'll be okay. But the number one thing in all these cases, and especially heat stroke, is going to be, hey, get them out of a place that's so hot. Get them to a cool area. Makes sense, right? So if they've been out, they're running a marathon or something, or they've been out running, or whatever the case may be, or even they've just been out playing, as a kid has been out playing outside in recess for a while, it's too hot outside for them to be playing, so bring them inside. Now, if we're dealing with heat stroke, you want to, of course, always do ABCs. Remove whatever is causing the heat stroke, remove the clothing, get them out of the heat. Put monitors on them, get a rectal temp going, Foley and an NG tube. Right, get that IV fluid going for hypotension. And like we said, do that active cooling. So we get down to 38. Make sure there's nothing else causing it, right? Because a fever, it can also cause some extra. You have altered mental sets, you always have to worry, is there something else? It could be endocrine emergencies causing hyperthermia, right? And then get them to ICU. Questions on hot and cold. Also find some stuff. So what about near drowning? So what happens when someone is drowning, when someone's drowning? So once they have an air liquid interface, it has an entrance to the airway, the victim's not able to breathe there. You can have drowning which causes morbidity, you have drowning which doesn't do anything, you have drowning with mortality. Back in 2021, there were about 11 drowning deaths a day. And of course, it might be more just reported. And it is almost overwhelmingly with children. There are 3 causes of accident death, children less than 14. So when the water gets to that level of the airway, there's a reflex inspiratory effort when someone's been holding their breath or their gas, they're unconscious. So they aspirate the water, there's an laryngeal spasm, they ingest the water as well, and that causes hypoxia. That hypoxia leads to unconsciousness, and then she's tachycardia, bradycardia, and also electrical activities on cases. Even a small amount of water aspiration can cause severe pulmonary derangement by interfering with surfactant. It really does make a difference. Now, this is pretty much, I don't want to say instantaneous because it takes time for someone to drown, but there are news reports and or urban legends, especially about concept of dry drowning, where someone started coughing a little bit while they were swimming, and then drowned while they were lying in bed hours later. So you might have parents bringing their child and say, he was coughing a little bit while he was swimming. I heard about this thing called dry drowning, right? There's no medical research, no evidence of it actually exists. There was one person who maybe passed away after really struggling while swimming. If I remember correctly, I believe the patient was disabled and may not have been able to have trouble breathing immediately following the incident in the water. So that small amount of water may have been enough to cause morbidity down the line. But most patients who are walkie-talkie who seem pretty okay, there's no real reason to go chasing possible drowning scenarios for kids. Get a really good history, cardiac history, seizure disorder, diabetes, alcohol, drug use, because that's really going to tell you why the drowning happened, right? One of the questions I always ask in the sports physicals, is there any history in your family of unexplained drowning? What am I looking for in a teenager who's about to go play sports that I want to make sure that you're worried about? Cardiomyopathy. How would that manifest itself when someone's running on a football field? Collapse. How would it manifest when someone is swimming? Drown. No one knows why they drown. I don't know. But there's any unexplained drownings in the family. Could be there's a possible family history of cardiomyopathy. What else happened? Was there a diving incident? Did they decide they wanted to dive into the shallow end of a pool? And then on the scene, how long were they under? What were resuscitations what they look like? That's going to help you. But the number one thing you want to do is, right, CLS, is there any hypothermia? If the patient is very sick, they might need to have ECMO, extracorporeal brain oxygenation. Yeah. Why? Okay, we're trying to find out why they drown. So a lot of times we might be sort of chasing this to see if they're also in the status. They're having hypoglycemic battle. So who gets admitted? I mean, this is someone, again, kid coughed up a little water when he was done by his sibling. Is that going to need to be admitted? So you want to know, first of all, are there any certain signs in your person, abnormal blood gas, or see anything on the chest X-ray indicating? And then you keeping at your hospital using them onwards, so it depends on what your so sending them home is fairly, there's sort of different opinions. So let's say again, they're on the site, seem asymptomatic, there's no coexisting condition, they seem really okay. They're like one of those one of those people who drown in movies where once they get a little like 2 or 3 suboptimal CPR, they're suddenly like, okay, all right, maybe. Some say they might be able to go home if they're asymptomatic. Others say you need to at least watch them for 48 hours, 4 to 8 hours, 4 to 8 hours, and see only see them home if something watching them overnight. What the book goes with is 4 to 6 hours with all of the following: no cough or respiratory complaints, no vital signs abnormality, abnormalities, got a chest X-ray, some other imaging, all looks okay. 6 hours you've been sitting on them, nothing is happening. Then really good. Okay. Questions? Carbon monoxide. We touched on this when we did the respiratory, right? Some have a pretty normal pulse ox, but they can have carbon monoxide. So this is usually going to be worse in the fall and winter. It's going to affect the whole family. What's going on in the fall and winter? Well, people have space heaters, people have wood burning stoves, charcoal burners. Maybe they even have a portable generator that doesn't have very good ventilation. Sometimes people riding back. Pickup trucks come in with carbon monoxide poisoning. Sometimes exhaust pipes are leaked by snow, and the car is going, and that causes carbon monoxide poisoning. It's also a pretty major contributor to deaths related to fires. Fire. Carbon monoxide poisoning needs to be ruled out. Not measured with the pulse ox, measured with CO oximeter. You might have cherry red mucosa, bright red mucosa, so you're not going to be saying the opposite. He's going to be treated with hyperbaric oxygen. When a patient is pregnant or if they're elderly, it can be a lower threshold of treatment. The reason for that is fetal morbidity at a lower level. And then if it was an accidental exposure, some heat, something leaking or something like that, they should be followed up in 4 to 6 weeks just to make sure they're doing okay. If it was intentional, if there was self-harm, that's when we right. Symptoms are pretty all over the place. Headaches, visual disturbances, the house is haunted, for example, ataxia, seizures, maybe even retinal hemorrhages, cardiac arrest. Pretty skates. So these are going to be patients who come into the emergency room more often because of just social reasons, or you might get them into urgent care because not all these cases have to deal with. Not all these cases have to do with economic factors. These patients are going to be very itchy. There's going to be burrowing at the site caused by the scabies, and there'll be these pruritic vesicles or pustules that almost go in these runs. Sometimes finger webs, wrist creases. Usually doesn't affect the head and neck. Sometimes you can even see mites over brown dots of feces visible, topically. And if you have these red papules or nodules in the scrotum, the gland, the shaft. When someone comes in with a rash, one of the things you want to ask is there anyone who has it? Because scabies is going to affect the entire outfit. That is that patient. You might see the burrows pretty easy on the feet. You also see the heels, palms, wrists, elbows, and silver breasts. Again, these short, irregular burrows about 2 to 3 meters. So what do? Well, we try to kill all the scabies, we try to kill all the mites, we try to control the dermatitis. We, as well as we trying to make sure there's no secondary infection with fluoridations, and this the dermatitis itself can actually persist for months after you're ready with the scabies and mites. So they still might come in really itchy after getting. How long do you have to have contact with these patients or with these family members before you get scabies? About 15 minutes. Okay. Scabies. Here are the burrows that might have webs of their feet, webs of their hands, their wrists here. See these excoriations, yeah.
Question about this, but actually, as far as what we're talking about, do you know if you can get them from a dog? Like, we had a patient who presented with it, and like, the two providers were like going back and forth. Because one was like, no, you can't, and one was like, yes, you can. So like, our patient's dog had it, and then they.
This is patient with hyperkeratotic crust. It's not actually pruritic, but it's extremely contagious. It's actually millions of mites. So everyone needs to be treated. Bedding, clothing needs to be laundered, set aside for 14 days in plastic bags. Need to be heated to a high heat or assisted to disintegrate. And then we use permethrin. One single application of the entire body for 8 to 12 hours. With a different diagnosis with different treatment plans. Once to 12 hours. There might be some pyoderma, secondary infection. The reason we do the second dose is because permethrin does not kill the oviduct for the eggs, so eggs hatch. Separates the total pregnancy. Then every school nurse's nightmare. Parents' nightmare. Lice. Pediculosis. So parasitic infection, skin, scalp, eyelashes, strong pubic areas. It is sometimes associated with overcrowded dwellings or we have 3 types. We have the pubic lice, body, and head. Body lice are actually seldom found on the body, not to find them on the body. You'll probably find them more in seams of clothing. Okay, and that's going to be usually if you got what's called trench fever or relapsing fever, typhus, it's not going to be your average much less hygienic areas. Maybe. Lice themselves are 3 to 4 millimeters of length, incredible itching, possibly causing deep excoriations. Head lines may look like little nits, and pussy willows, about this close to the skin. So get rid of all infested clothing. If there's any social situation involved, deal with that. Pubic lice needs a permethrin. Permethrin, 1% rinse and 5% cream. Head lice, 5% cream rinse or nix. And resistance is fairly common. You may need to use malathion, 1%, which is actually highly volatile and inflammable, so make sure you do that first. So what's interesting about this patient here, I mean, this is a nice microscopic follow-up of the patient, but you can actually see the nits here in the hair, as well as this is an empty nit here on the top, and then there's one to the bottom. Talk about other bugs or insects, skin lesions. Might be a localized rash, is pretty pruritic. Maybe a furuncle-like lesion. Sometimes you might not see the insect inside the furuncle. Ciliary erythematous patches that migrate. Might be some generalized urticaria or multi-part. Sometimes we can see the insect as it bites. Sometimes the insect bites while asleep. A lot of people come in saying they have a spider bite. Usually not a spider. Never a spider. We'll see later what spider bites look like. If they're really worried that they got bitten by a ground recluse, they would know. Especially after a few days. They would know. We'll see why. Black widow. Fleas, you have the papular urticaria, saliva bed bugs, parasites bedding furniture. Bed bugs not necessarily limited to a certain socioeconomic group. And again, it's going to be papular urticaria clusters. Ticks we've talked about many times. Chiggers or bed bugs in pruritic erythematous papules around the waist. Sometimes you might actually see the chiggers in significant papules if they haven't scratched them. The patient chigger bites if they're camping, but close you might actually see a red chigger. So how do you prevent it? You just don't go places with the bugs, right? How do you treat it? Well, you can remove it carefully with tweezers. You can see it after you apply some alcohol there. Don't remove ticks with your bare fingers. Corticosteroid creams can help with itching. Antibiotics if you have a secondary infection. If there's a sting, you can use mix of pain powder or meat cinderator mix with water to cream. And if there's a risk of anaphylaxis, I need a immunotherapy. Bed bugs, if someone does have bed bugs now, method no longer really works. If they can live there for a year without feeding. That's it. All right, now let's talk about spider bites. So first is the black widow. Black widow's bites are painful. We don't just wake up and oh, looks like I was bit by a black widow while I was sleeping. It hurts a lot. The site is fairly erythematous. The patient's going to be systemically ill. They might have hypertension, tachycardia, muscle cramping, myalgias, vomiting, diaphoresis. Within 1 hour, the area becomes erythematous, and you have a sort of a targetoid or halo lesion. And then and there might be some neurotoxicity. Might have be some seizures, respiratory arrest, right? All these patients get antivenom, Tdap, ABC, neurotoxicity, and of course, because they're having some sort of neurotoxicity, because they're coming in with hypertension, tachycardia, all these other things, you have to realize anything else causing it. You're going to get a full flag. Don't assume just because they say they have a spider bite, they have a funky looking lesion, and they're hypertensive and tachycardic diaphoretic. That's something. The brown recluse has a painless bite, but it's necrotic. Necrotic bite. There will be a characteristic erythema. There are sort of blue-gray macules, a halo of pallor, which within 1 to 3 days may, although it is rare, may cause hemolysis, systemic hemolysis. Maybe sometimes, again, super rare DFC attack. but usually just a sort of necrotic area around the bite. Again, check for tetanus. If they are having hemolysis, give them steroids, maybe give them admission, make sure you have Emergencies, make sure they check their kidney function for just to make sure that they.
Necrotic, do they have to do like body bleed?
So it's not necrotic like necrotizing fasciitis. That one area is necrotic.
So if you just like.
You just would have to treat the symptoms until it. While we're continuing toward family, let's talk about scorpions. Let's say you have like a family camping out in the southwest, right?
Kinda sick.
And all of a sudden they
It's a funny
get hit by a scorpion. Within this neurotoxin,
like
this is one thing that the sodium
That should be on Tuesday.
neurons. It affects both the sympathetic and parasympathetic system. The area itself is extremely tender. It seems very painful. They make all these kinds of. So usually the symptoms come on within 15 minutes of the sting. Might be some local area for his pain, but the area is hyperesthesia around the area. There might have some oculomotor dyskinesia. All over the place, spasms, tongue gesticulations, salivation, hypertension, heart attack, arrhythmias, and agitation. You really don't need any labs unless you're fairly certain, unless you're not really convinced it is a source of some other systemic issue. If they have hypertension, beta blockers would be best to deal with hypertension, tachycardia, things those are. Otherwise, if they're treating allergic reaction, anaphylaxis, local wound care, but if things are getting pretty severe, you might need. Bees, wasps, vespids, fire ants, all these can cause. They do have a little bit of venom in their stings or their bites, but often the greater issue is the reaction. So ideally, you would find out what caused it. For example, honeybees can only see when they're provoked, but their venom tends to have a greater elasticity than other venoms. But they only sting once and then they die. Africanized honeybees or killer bees, quote unquote, can be more aggressive, and then when they sting, they actually release a pheromone to attract other bees. The wasps, they're mean, they're carnivorous, they can bite, sting multiple times. And their venom can actually affect vascular tone permeability and actually increase histamine. There's some cross reactivities. Just because someone is allergic to bees doesn't mean they're only allergic to bees. In fact, some patients who react to fire ant venom are more likely to react to bees and vice versa. But just because they're reactive to bee venom doesn't mean they're reactive. So there's 4 types of presentation. One is going to be just your basic pain or edema, pruritus in the area of the sting, called vasoactivity. They might come in toxic after multiple stings. They just got attacked by a bunch of bees. Now they have a headache, fever, drowsiness, muscle spasms, edema, as we see, maybe cause liver failure or abdomen in some cases, even some PICs in cases. And then you have the migral phenomenon where in 15 minutes to 6 hours of the sting, urticaria would be swelling, and 1 to 2 weeks after the sting, serum sickness, rash, fever, breath. Of course, you want to do ABCs and analgesia, get rid of any stingers. ISIS, very well, steroids. If they're anaphylactic, there's anaphylaxis. But if it's just like, it's just a patient that's stung by a bee, and they're doing okay, we usually go for it. Any questions on the insect kingdom? None yet? We're about to move to snakes. The fun thing about growing up in Texas was every year, the enemy, right? So there's snakes in Texas. All right, snake, water moccasin, rattlesnake, and oh. So there are two types. There's the Lepidae, coral snakes, or the pit vipers. And they're going to have different types of, copperheads. Copperheads. So they have different types of reactions to it. 25% of the time, it's a dry bite. There's no sign of contamination. And it goes eye on them. Super helpful if the patient has a picture of the snake, because that helps us to try to figure out what sort of treatment we need to give them. Was the snake, did it have a triangular head, right? Did it have a rattle? It's super helpful. Was an elliptic eye with their heat sensitive pit vipers, right? So if there's ideally, if there's a picture of it, you know the type of snake, that is really helpful in speaking of treatment. No one should ever suck on a snake bite. Don't do tourniquet, don't do electricity, don't try to cut the bite off. None of that's good. People try to do that. Let's say it's a coral snake or a lepidae. So there's little or no pain, no local, no necrosis. You may even see the fang marks. Within 90 minutes, patients seem to be weak or numb. And hours later, maybe systemic symptoms. So they're staying tonight. If they say they got bit by a snake that looks like a coral snake, they're not going home because the symptoms might come up much later. Sleep. Tremors, drowsiness, euphoria. That's nice. Salivation, slurred speech, diplopia. Death is still extremely rare, but still need to watch those ABCs, EDAP, and the other side of the equation, pit vipers, the local burning pain immediately after the bite. So again, we're seeing this painful bite versus painless bite. And then within 5 minutes, they're getting weakness, nausea, and vomiting. Paresthesias, this edema is going to spread over 6 to 12 hours. Might have hemorrhagic plebs, hemorrhage, DSE, coagulant, radical. And then they'll need ABCs, TDAP, GSE. We may need to call the zoo to get them. And they specifically would recommend antivenom Propat, which is made from the venom itself, as opposed to an antivenom. So, I mean, if you'd be doing one of those old SAT analogy things, right? We had Black Widow, and ground recluse. One is painless, one is painful. We had pit viper, and we had coral snake. Painful, right? One happens like almost immediately, and one happens over 2 hours. Like we can try to start seeing them in different columns. Scorpions are almost always immediate. Extremely. So let's say you say, you know what, I'm going to stay far away from the Southwest and I'm going to snakes or I mean, let's go to the beach. Beaches. Nothing happens. Okay. So let's talk about what happens at the beach.
Nice.
So, all right. Well, let's make things. Let's say you don't even get attacked by sharks or sea creature. By the way, we're not talking about sharks. We can talk about sharks as being one, so don't do it. Just deal with the trauma zone that's been by shark. They're probably going straight to surgery. But let's talk about, let's say someone's walking on the beach, she's diabetic, let's say, and 2 weeks later, she's affecting her legs are like bright red and painful, right? What could be going on? Why did I make this patient have
Cellulitis.
So it might be cellulitis, right? Well, she was hanging out on the beach and she was probably doing some walking in the bay. So in Chesapeake Bay, we have to worry about it. Which means we don't treat it with a normal cephalexin, you don't have to worry about it for okay. And they even cause fluid, vasculitis, necrosis. Freshwater, you have to deal with Aeromonas. So again, fluoroquinolone. And it's usually diagnosed late because people think, oh, cellulitis is just giving the standard stuff back. Now let's say there was a creature, some marine creature bit them. So one thing we want to do is just remove any possible teeth or spines that are indications. If it's, and treat the pain. If there's some by jellyfish, keep iocane, sea nettle, baking soda. Voltage or baking soda. Everyone good with now the patient. Let's talk about thermal. So we will give us another 5-7 minutes. Okay. Okay. So first of all, what caused the thermal? Actually, do you guys need to break down?
Let's keep showing.
Okay, I'm seeing this. Thermal injury. Identify the source of thermal injury, electrical, oil, hot, cold, they have oil splashing. How long ago did it happen? What happened exactly? And could it be some concurrent trauma that goes with it? Could it be some concurrent trauma that goes with the whatever the mechanism of injury, right? Get a really good detailed medical history, especially anything related to wound healing. Are they diabetic? They have immune suppression. Are they smokers? Not at the time that they were being burned, were they smoking? Right? If their skin smoking, they smoke cigarettes. But look for stuff that's fishy. Circumferential burns doesn't fit the mechanism of injury. You really have to worry about that. Trigger warning, I guess, for some of the pictures because they're a cigarette burn, unfortunately. If this is a circumferential burn, it just doesn't make sense. Most patients had it, unfortunately. Patients feet were I did have a child come in with a circumferential injury, and they wanted me to sign a paper saying that it wasn't on accident. We need to. It's a major child service has already been. Child service already was forward, right? But they just went to sign a paper saying. All right. So there's different types of. Most burns are either superficial that I've seen are superficial or first degree or second degree. The difference being, is there going to be some sort of blistering? Usually that's going to be because the upper dermis has been involved with the second degree burn. Most sunburn, for example, are just going to be at the level of the epidermis, sort of a dry blanching. They're both painful. Both painful. Once you get deeper partial thickness, where it's affecting the lower dermis, or even full thickness, there's decreased sensation, and you start seeing changes in the color, yellow, white, maybe even getting black or brown, and it's not going to be blanching because you're so deep. Normally, first degree burns will heal without common factor for days. Second degree burns, which are superficial, again, in a few weeks. Deep second degree or full thickness burns, more likely to take 3 to 8 weeks, or maybe 8 weeks, like this. You look into the anatomy of it. First degree burn is only the epidermis. Second degree is getting deeper into the dermis. Third degree burn is all the way down to the system. Treatment is going to be based on how severe the burn is and how widespread the burn is. And we use something called body surface area, PSA, to determine how much of the patient has been burned, or TBSA. Without getting into too much of it, in general, we can rely on the fact that the palm of the patient's hand is usually 1%, or the rule of nines, which makes more sense with adults. Front of the leg is 9%, back of the leg is 9%, torso is 18%, each arm is 9% total, right? The head is 9% total. But it gets a little more wibbly wobbly with children and infants because they're just proportionate. So this sort of chart is very helpful.
What age are you considering someone an adult proportion?
I would honestly say probably over 10, and we're going to see that the number of age 10 does come up. Maybe that's that criteria for admission. Because by then they're, even though they may not hit puberty yet, they still are more. So, ABCs. Let's say someone decided they're scared of the beach, or scared of going to the Grand Canyon, scared of traffic, scared of the barbecue. The coals blow up in their face, they're saying to the barbecue. If there's any neck edema or wheezing, if there's any burns to the face, any singeing of facial hair, eyebrows, soot in the nares, mouth, or airway, certainly voice change, doesn't matter how stable they look right now. We need an airway. Need an airway. Early intubation, because it will, in 100% humidified oxygen, it will swell them within minutes to hours. Doesn't matter how good they look right now. Once you see any of those signs, if there's more than 10% PBSA, then you might need fluids and every burn, you need to check your tetanus. Every burn, make sure your heat control is good. If there was a trauma or explosion or house fire, consider other causes, especially if it's a shock fire, worry about carbon monoxide. Explosion, worry about the TMs, worry about the internal concussion. So, part component of the goal is to describe how much IV fluid is necessary for these burn patients. First of all, we're giving lactated liquor. And you give the first half in the first 8 hours, and then the second half over the next 16 hours. So with adults with only 4 milliliters times the weight in kilograms times the percent of total body surface area, which has been burned, pediatrics would be 3 times the weight times TPSA. Goals to get about a half cc of per kilogram per hour. And only if there has been 16 hours. Used to be that we would give silver sulfadiazine. So not good if patients have G6PD, not good if patients sulfur allergies, not used in the face, also gets the color of skin, and they found out it doesn't do a great job with healing. So we really don't use it anymore, but you might end up where they still use it. You can use other compounds. So what about a blister? What if there's a blister? So some people say, yeah, go ahead and write it. So if you drain, painful. Some will say, well, you're introducing bacteria to a sterile area. Right now, there's no break in the skin. Why would you create a sterile environment? So if it's pretty large and painful, consider debriding it. If it's placed like in a joint or crease, there's going to be a lot of stress there. So debriding it. Otherwise, really, I would suggest leaving it intact. You may need what's called an escarotomy. Slide, and it's a burn center. What's an escarotomy? Well, when an eschar is formed over an area, and it's eschar is like this hard, it's like a precision extremely hard. You cause respiratory failure or Parkinson's syndrome. And those 6 Parkinson's syndrome, you need 6 P's, have you heard of that? Where it's really a circulatory issue, but painless, pallor, open pleasure with therapy, with the touch, fail for certain. So if it's a deep burn and you have those 6 P's, and because you have that hard eschar, you have to worry about Parkinson's, certain burn, you have to worry about it. So they might need to usually just go to surgery to get the escarotomy done, but you might need to do emergency and a referral criterion. So who needs to be referred? I'm going to go over this very basically. If it's a partial thickness burn over more than 20%, more than 10% of total body surface area depending on age. If it's a full thickness burn, more than 5% in all patients. If there's a major joint involved or perineum, it's just a partial thickness, those patients you can make a call if they really seem pretty stable and they can follow the burns in their outpatient. It's usually fine. They can be transferred there. It's a tiny partial thickness burn, but it is important that this be referred there. High voltage electrical injuries include lightning injuries. We'll talk about that after the break. Significant burn from caustic chemicals. Anything with multiple trauma, in which the burn injury is the greatest risk of morbidity and mortality, right? If the trauma is the greatest risk, we can serve them in trauma and transfer first. Any burns with inhalation injury. Any patient with significant ongoing medical disorders that can be covered. If there's no pediatric personnel, no pediatric burn unit at your hospital, you can transfer. The place that can deal with them. And if there's any special social, emotional, long-term rehab, including child abuse substance. Let's take a break until it's 1:58 now. Let's take a break.
I don't remember.
So fairly rare, almost less than 3% of all burns, but there's a higher morbidity, higher mortality, and nearly a third of all burn deaths are due to. Thermal burns are fairly quick, usually. Chemical burns are going to be longer. It takes longer to get the chemical off the patient. And usually when they come to the ED or they come to your office, they are continuing to be burned. To find out what happened, let's start. How concentrated was the chemical that landed on them? How much? How long was it on there? Shower right away. How deep did it go? And what sort of chemical is it? What's the mechanism of action? Oxidative, reductive, corrosive, for example, hydrofluoric acid. The way hydrofluoric acid works is it actually that those hydrogen ions first to that cellular damage, then the fluoride ions start scavenging the cellular stuff like calcium and magnesium and stop sodium potassium ATPase. Basically, what ends up happening is hypocalcemia, hyperkalemia. So what you need to do is you need to put topical, that's important to know, for example, hydrochloric acid. Putting topical calcium on them is going to find all those fluoride. Knowing what caused the chemical and how it works. The important difference between acids and bases is acids cause a coagulative necrosis, while alkalis sort of create a liquefactive necrosis. It's much deeper, much more. While you're treating it, you can try to start with getting a baseline pH, but that doesn't tell you how sensitive the injury itself is. Yeah, what does that mean?
Coagulative versus what's the active?
Okay, liquefactive, alkalis will actually turn the solids to liquids. Acid burn. Alkalis actually liquefies through flesh. Okay. Okay. And always check the patient's OR bearings for any years. So the number one thing you have to do is decontaminate the patient, get that chemical off. First, remove all clothing exposed to chemical agent. Don't wait to find out what chemical it is to get the clothes off the patient. Okay. Make sure there's no powder on the skin, you brush that off. And then irrigate it with soap and water, and usually that's enough. Now, there's another reason why you have to make sure to get rid of all the contamination. Why? For yourself. You're going to be touching the patient, and you don't want to be the next patient. Right? If it got in the eyes, you can use a Morgan lens. Some of us spoke about that in the lab on Monday. See a picture of it in a minute. And ABC. But this is one of the times when it's interesting, ABC actually is going to be, it's going to be EABC, need exposed patient, because you can't be trying to put an airway in a patient while you're continuing to be burned by it. You expose them, picture from Morgan lens, almost like a contact lens. And then you actually run IV fluids through there. So just an IV bag.
Terrifying.
Really, really helpful. Sits there and just flushes that.
It's like a big contact.
Check for any concomitant injuries and consider electrocution. There's two types of electricity. There's AC, there's DC. Most homes, most offices, most generators are AC. These are technic contractions. Why is that important? In some ways, it's actually more dangerous because technique, things are going to clamp down. Patients are going to get stuck to the thing that's electrocuted. DC, direct current, is just going to, like batteries, railways, most electronics, we're just going to blast the patient away. So they're immediately no longer, it's a pretty strong current hitting them at once, but it's not a continuous current. EV charging stations, most people have in the house are AC, but it is a fairly high voltage. There's one of those fast charging electronic vehicle stations that you might see like in parking lots. That's actually DC. Lightning is actually going to cause burns to the skin, cutaneous burns, higher voltage electrical injuries, skin burns. Internal damage from electricity actually. Pictures in a minute. It's interesting. Lightning can actually cause a very specific type of scar called a Lichtenberg figure. These are patients who have been struck by lightning. Crazy scars on their skin. What do you want to do for these patients? Well, ABCs, ACLS, and EKG, there will be cardiac abnormalities. Imaging is going to be based on the trauma. If there's a loss of consciousness, a burn in the face, or neural damage, you might need to get a head CT. You should get a CT. If there's no history of trauma, still consider spinal mobilization. If they weren't blasted away by the electricity DC from the DC voltage, still get spinal mobilization because those technic contractions and those fractures of the bones. You need, if there's a high risk patient, meaning there's a direct strike, there's traumatic, there's EKG chain, high voltage, you need to be on cardiac monitoring for at least 24 hours. Labs may include cardiac markers, so you want to make sure that there's cardiac. CK will probably be high, so probably muscle damage. Looking at me too, with muscle damage. Pregnant patients get very high. Everyone who's pregnant gets ultrasound. And if they're greater than 20 weeks, to get fetal. Well, who's going to go home? Good, well, no, so it depends. It's fairly low voltage, and they have no CPB. Injuries may be minor. EKG is totally normal. They're pregnant. They've had the 4 hours of fetal monitoring. They can actually go. If they've been struck by lightning and they've been hanging out for 8 to 12 hours and they're just totally chill, that's a really great story. So they can go. Everyone else gets it. Let's talk about kids. So, I mean, there's going to be kids who sign a decision for an electrical outlet to see what that looks like, right? So there's going to be fairly low voltage injuries, if that is the case with the household current. They're alert, they're awake, it's unlikely there's going to be anything. If there was a brief contact with a high voltage source, there may even be a contact current. High voltage, again, we have to worry about that locking on that technique. And if there's lightning strikes, might cause asystole, something called blast trauma, so that's part of it. Let's say you find a baby who's been chewing on an electrical cord. So this can cause an oil burn on the lips itself. Maybe you paint this gray to white tissue surrounded by thin rim of erythema, which may become edematous and swell in the next several hours. Assuming the patient's airway is pretty clear, they can go home. However, they will form an eschar. What you have to worry about is that 1 to 3 weeks when that eschar comes off, it may actually cause a labial artery. So really, really good follow-up. Be aware of watching. Because you can't keep them out of your eschar. Don't happen. You'll be aware of this. Let's stop this. Also, I just want to clarify with the snakes. So I talked about 2 types of snakes. Those are families of snakes, not specific snakes. Those are families of snakes. 2 types of venomous snakes: the Lepidae and the Croatinae. Basically, rattlesnakes are the pit vipers. Close. There's my prayer. All right. Well, let's talk about. First, we'll get something stuck underneath there. Environmental, right? Paint chip, wooden sliver. So first I'll give them a good digital block. We all want to have digital block. By the way, my favorite type of digital block, I don't know if you guys talked about it. Talk about the ring block. Out of fine, right? Pretty painful. So what I like to do personally is if you get a good 22 gauge or whatever, with the bevel facing up, you go into the crease of the finger where the finger meets the palm at a 90-degree angle. And just get light pressure as you go in. Once you hit inside the sheath, 3 cc into the finger is one thing. But you like the ring block. If your preceptor wants you to do a ring block, all right. Anyway, so numb up their finger because you have to go in there. And you may be able to manage it conservatively if you have to take it out. Make sure you don't affect the nail bed at any point, because it's effective or make it. Let's talk about maybe a paint chip. You can just sort of like create a small U shape with a scalpel. Like a paint chip. Usually fairly painful to have it underneath the fingernail. Let's say you have a splinter stuck underneath your finger. So assuming it's somewhat poking out, you can actually take a 25 gauge needle and just sort of get it right until the hollow of it is right underneath the splinter, and then knock it out. If it's really stuck in there, you may need to grab it with a scissor. They're fairly numb, hopefully. And you will have to do a whole nail excision, like almost a whole nail excision. But again, be careful not to affect the derm. And there's fish hooks. Fish hooks, okay. So assuming there's no eye involved. Once the eye is involved, totally considered. So fish hooks, for those who haven't seen fish hooks, actually have several barbs, sometimes more than one. And if it's a well-made fish hook, it's easily embedded in skin and not easy to come out. Why would I say a well-made fish hook? That's the point of a fish hook, right? The point of a fish hook is to grab on easily and not let go. So what happens when it ends up in the hand and the finger? So first of all, get rid of all the fancy stuff. Get rid of the line, get rid of the bait, the lure, anything, get rid of all that to make it look easier. Make sure it's really nice and done before you start around in there. If there's any exposed barbs, cut them off or cover them so you don't get torn up. If after you move the hook, looks like something's missing, get an X-ray, make sure it's something. Call specialists if you have joint involvement. Make sure that it's tetanus. And even if it came right out of the fish, don't need any reflecting. If they start having infection. If they do have infection later, then you need to talk about Vibrio, need to talk about other chronic bacteria. Let's go through a few methods. And again, like this is just sort of my section. There's going to be 4 types of fish hook removals we're going to be talking about. More superficial down to deep. Maybe I'll incorporate into procedure that I'm this time. Always wear eye protection. So string yank. So with this one, especially with just a single barb, you push down on the long end of the fish hook and pull it with a jerk it out real quick with the string. By pushing down, you're actually disengaging the barb. Alternatively, you can actually poke the needle into the same hole that the fish hook is going into. And then cover the barb with the hollow board. Way, the way I learned, but probably with other neat tricks, would be just push it all the way through. Continue pushing it through, cut off the barb, because it's only meant to pull going the other direction. Push it through, cut it off once it's done that way, and then pull it out. Or just push the whole thing through. Attach the shaft. Good. So, try that. And then just to clarify, zipper entrapment again. Make sure everything's well lubricated, it's enough. Consider systemic analgesics, betadine, lidocaine without epi, or do it, like with EMLA or EMLA, which is 45 minutes. Cut the zipper away from the clothing. Why? Because that way you're not pulling on the clothing entirely with the zipper. Just also you don't have to destroy the entire clothes, just the zipper. You can also confirm to urology, you can remove it. So again, depending on where it is, if the flesh between the teeth and the zipper, just sort of cut along the zipper teeth above and below. I may be able to just cut the teeth below and actuate and zipper. If it's stuck in the slide itself, we have to put this median bar. We use clamps to pull the zipper apart. And maybe it's some zipper so people can see it, so which work. Exposed to pull the exposed teeth apart. And if you're going to be cutting anything apart with the big pliers, metal cutters, have the patient looking at the all right. Any questions on that tower? That's probably the biggest potpourri one today. I don't know. Where to go.
It is city on. I think it's. No, I'm saying I just got in here. Oh, like recently.
Okay, so let's just go over some terminology. I know we remember this from way back. Macule, flat non-palpable, less. Patch, flat non-palpable, more than 5 millimeters. Papule is palpable, less than 25. Plaque is greater than. A nodule, centimeters. Okay, a nodule is elevated, lesion greater than 0.5 centimeters. The cyst is where this stuff in may be expressed. And then if it's filled with fluid, clear fluid, either vessel or pustule, can be filled with cloudier purulent fluid. Crust is going to be in that liquid debris is dried onto skin. Scale is going to be thickened. Stratum usually white. Say terms like unification, duration, thickening, so wheel, dermal edema. Petechiae are these pinpoint capillary growth vessels. Purpura, the large dermal blood. Now, important thing to know about petechiae and purpura are they are not blanchable. Petechiae and purpura are not blanchable. And they're also usually divided into palpable versus non-palpable. Do we know of any infectious diseases that might cause purpura?
Coronavirus.
Any origin?
Meningitis.
Meningitis, actually, yeah.
Coronavirus.
Yes. And are there track marks? Signs of IV drug use. Patient. We mentioned this back in foundations. So we probably a doctor right now, he wrote it. One day, different interaction with the skin. Okay. We started talking about any dermatological emergencies that are immune mediated. urticaria. These erythematous or edematous transient needles of varying size that sharply defined, slightly raised. What could cause them? Well, most of the time we don't really know, but it could be if there's contact with food allergy, maybe a viral infection, maybe certification, maybe even stress. But usually you're not going to find the answer. They often going to be fairly pruritic. And here's the thing with things which are itchy. The reason why we itch is that was designed so that we can take things off our skin. That's not everything we don't have on our skin. So that's what we scratch. Scratch itchy things is when we take things off our skin. If it's not has nothing to do with something being on your skin, it's a histamine reaction. Scratching going to help. No. So scratching an itch is not going to help. So first thing you want to do, first thing you want to ask is the respiration involved? Are we looking at angioedema? Does the tongue and the lips, are they swelling up? If so, make sure there's no anaphylaxis. That'd be unfortunate. Usually we use H1 blockers, loratadine, Benadryl, Zyrtec, etc. What's the difference between first and second generation? Drowsy is going to make you, right? You can even use H2 blockers, the Ds, metadine. That can help as well because they're also antihistamines. Might want to use some pioprezone for 5 to 7 days, maybe take a break. Unless you're diabetic, you might be a little careful, more careful. Topical steroids aren't going to do that. Avoid whatever causes it if they do know, not go to the dermatologist. So what happens if they started taking something with a prill at the end, the Synapryl, Rapidol, and now they're coming back with this cough, so persistent cough for several months. An R, that's a low-level angioedema. That's called an ACE inhibitor-induced angioedema. So it should be taken seriously, right? Usually it's not life-threatening, but it is a low rate. Aspirin, NSAIDs, and alcohol may actually be worse. Questions on that? Good for an erythema multiforme. So erythema multiforme is acute immune-mediated, distinctive target-like lesions. What's worse, erythema multiforme major or erythema multiforme minor?
Major.
How many people say minor? People say major. How many people say no such thing? No such thing. We got rid of it. We used to have erythema multiforme, minor, then major sliding to SJs and EN. Now it's just erythema multiforme, minor is just a fancy way of describing. Usually what's called erythema multiforme is usually infection, maybe herpes, maybe mycoplasma. They're symmetrical on the dorsum of the hands, of feet, sensor surfaces of extremities. Sometimes it can be involved in the eye, but pretty rare. And usually it's going to be those target lesions of the cyanotic center. Remember we talked about it being the sort of the true target with 3 different colors, maybe bluer in the middle. We have the central dusky purple on the outside, the elevated down this pale green surrounding the clear. So what do you want to do? Well, this isn't terribly life-threatening yet. Treat the cause, stop the agent, give them prednisone to knock down the reaction. We're dealing with immune-mediated issues. Acyclovir is those caused by herpes, speaking PLS, antihistamines, magic mouthwash if it's in the mouth, medium steroid. Follow-up, usually fine in 2 weeks. However, if there's no systemic manifestation, involvement. In other words, we might be looking at something severe, like Stephen Johnson's. And these are severe mucocutaneous reactions, usually to a more mucocutaneous rate. Extensive necrosis and detachment of the epidermis, which means what's going to be positive, which sign? Remember? Nikolsky sign, right? The difference between SJS and TEN is how much body surface area is affected. Is it less than 10%? It's sebum. It's more than 30, it's TEN. If it's between 10 and 30, we call it both. It's almost a 30% mortality rate. And usually it's caused by some sort of medication. So they may come in starting off with just having a few days of fever, myalgias, flu-like illness, maybe even conjunctivitis, which is the beginning of that mucous membrane involvement. And then they start having these tender localized erythema, starts becoming more diffuse, or legs, maybe the positive Nikolsky sign, where you're not pressing down on the blister itself, but you actually press down on intact superficial epidermis, and you move your finger along the skin, and you'll just sort of like near the area, and you'll tear the epidermis. Like very easy. Tear the skin apart. They will have those mucosal lesions. They may have severe conjunctivitis, discharge, may have genital ulceration, vaginitis. So diagnosis in the ED is most likely going to be skin biopsy. You can go ahead and order it. It's not going to happen. If you suspect SJS or TEN, get on it right away. High risk of complications. Stop whatever drug it is. Constantly commit them, supportive, right? It could be anti-epileptics, it could be antipsychotic medications. If it's extensive or there's systemic toxicity, they need to go to critical care. Get derm on board, maybe get optimal on board. They might need to end up in a burning. IV fluids, oral solution can help with blisters, fluid compresses. And if there's an infection, pemphigus vulgaris versus bullous. Now, pemphigus vulgaris, this is actually has a fairly high mortality rate if you don't catch it. It's large flaccid fluid. Because are more prone to ruptures, skin ulcerations, exfoliation, and again, the positive Nikolsky, and mucosal involvement. These are going to be 40 to 60-year-old children. It's immune-mediated rash. It's really going to be caused by drugs, medications, ionizing radiation, pesticides, sort of therapy of plastics. Again, you could diagnose it with a biopsy, serum fluorescence. No one is going to take this seriously. Diagnostic, it's clinical. If they do fluid and electrolyte management, resuscitate as needed, they're on board only if they're in fact needing antibiotics. And eventually they'll need some sort of immunosuppressive method. Ask the derm what they will do. Bullous pemphigoid is more chronic. There's less toxicity. Again, it's autoimmune. They tend to be older when that first comes on. And the blisters are much larger, and there's not as much mucosal membrane. And negative Nikolsky. So what's the lesson from all these? Positive Nikolsky means bad news. How do you treat them? Call derm and say, hey, I've been at bullous pemphigoid. But most likely you'll be sending steroids, PO steroids, drug eruptions. We're not going to talk about all this, but just know, like these are all possible reactions on a drug. Photosensitivity, phototoxic, maybe severe sunburn. So, drug examples, your classic morbilliform or macular drug eruption. Fixed drug eruptions. That is, they say, oh, I get every time I take this medication, I get this reaction right here in this one spot, every single time. Okay. I was like, he said he was allergic to amoxicillin. I'm like, okay, how about septic? I don't know. So, but what happened when you took amoxicillin? He's like, I got it at a dermatologist foot ever since. So, I mentioned my dermatologist is stopped taking amoxicillin. So it was. Okay. The ones you really need to worry about, we'll talk about those. So there's something called exfoliative erythroderma. Starts with itchiness, tightening of the skin, a low-grade fever. Starts to get acute, generally warmth, and then becomes a non-tender erythema, scaling, exfoliation. Again, what's going on? If it's a significant amount of exfoliation, we need an urgent derm consult. We need to be admitted. Systemic steroids correct any hypothermia or hypovolemia that comes from the exfoliation. Dress is going to be one of those where if you know what dress stands for, you know everything you need to know about it. Dress is a drug rash with eosinophilia and systemic symptoms. So, I just explained those cycles. It happens right after you start a new drug. Usually anticonvulsants are solved, but maybe a genetic disposition. And they have systemic symptoms, fever, rash, high effect the liver, the kidneys. Might be just an erythematous scaly rash. Might be Stephen Johnson's. And they don't have eosinophilia. Stop meds, systemic steroid supportive care. This patient has eosinophilia, yes, systemic symptoms. This is taking fentanyl. Okay. So we have a little comparison. We have a 13-year-old male who is recently diagnosed with epilepsy, presenting with a fever and a painful rash has developed over the past day. Getting a new medication, but his doctor parents aren't sure what it is. So why don't you, there's 2 or 3 big groups discuss what could be going on with this. What are you worried about?
Let me tell it.
What could be causing fever and painful rash?
Yeah, so. Oh, it's newly prescribed.
What could cause these symptoms? That's jazz. Yeah, whatever epileptic medication is taking. So is this something you can handle in the clinic or do you need some emergency? What clinical finding would you pass it now? What would tell you this is not meningitis? It's probably checking the
Ernix and Brzezinski.
so checking. I'm thinking checking the mucosal membrane, right? What test would you want to order? BBC, right? Theory again. It's LP maybe if you really are worried about meningitis. And how would we treat it?
Stop the HMOs.
Stop medication, fluids. What else? If it's immune mediated, they might need steroids. Where are they go? During ICU. Keep the fluids going because that's going to be causing. Talk about infectious causes of the dermatological pregnancy. Toxic shock syndrome. Are going to be some pretty interesting pictures. Toxic shock syndrome is often caused by group A strep, basic group A strep. It can cause necrotizing fasciitis, soft tissue infection. It's associated usually with postpartum women. It's not diffuse erythroderma of the coast at all. It's localized that look. But it can cause hypertension, multi-organ failure. You have to be worried that there's systemic illness, soft tissue infection, and admit them. Need urgent or emergent debridement of the infection, cause resuscitation. The next one is a little more common pediatrics. We have in any age, and that's Staphylococcus scalded skin syndrome. Scalded skin. The toxin mediated reaction. This one is caused by staph. The other one's caused by strep. This one's caused by staph. It's macular erythema, skin pain, and eventually progresses, starts from the axilla and neck skin folks. It progresses over the entire body. Cause desquamation, perioral crusting, and again, positive mental positive Nikolsky sign, but no. If you have positive Nikolsky, it's an sign, right? So you're gonna need to be admitted. IV antibiotics, great staff, so that's what. We're about MRSA, vancomycin, and vancomycin. Those are IV fluids. Cellulitis is a lot less emergent. It's a bacterial skin infection involving the subcutaneous tissue. Erythematous, edematous form, soft tissues, and there. Comes from a wound, can cause it as well. Small breaks. Immune suppression, diabetes. So diagnosis is really clinical, but you can get a skin culture, which would be a pretty good idea. You can make sure you're treating the right organism, maybe a CBC if there's. And this is one of the things when a mark would be really helpful. Why? They can outline it and see the threads. Antibiotics. Yes.
With something like cellulitis, if you're getting a skin biopsy, do you just need like skin from?
You don't need a skin biopsy, just a cold.
I'm sorry, skin culture, yeah.
Just a swab.
You just have to swab the skin. You don't need to like cut it off, right?
So, and we talked about this a little bit in, I believe, when we're doing splints, right? If it's human or animal bite, then I can now look for humans, pastorally for animals, they're gonna get augmented, in my cloud. Otherwise, treat them, just go to infection, staph and strep, if they're diabetic, speech, as the cause, always some gram negative. Erysipelas is just a variation on cellulitis because it's only cutaneous, it's much more fibry red, with the sharp demarcated borders. Lymphadenitis would be where you see a linear pattern, but it's not as indurated as erysipelas. Cellulitis. Those are also treated fairly and more or less the same. Fasciitis. Thread infection spreading even further down the fascia. Once you get the fascia, things move quick. It's usually marked systemic toxicity, severe pain, skin surface may become numb, there might be signs of blue, gray, color changes, crepitation. Or sound of autumn leaves as they walk. Tendon or nerve impairment. And now, demonstrate Monday activity. Abscesses. So these are bacterial infections filled with purulent fluid, not like our here. There's usually a purulent fluid in there, not package, and it's usually under a follicle. There's induration, there's tenderness, there's flexion. Usually Staph aureus or MRSA. Treat it with IND because what has happened is the body has created a barrier blocked off an infection. Antibiotics and therapy. It's really the only treatment if they're surrounding erythema. If it's really tiny, it's a tiny little pustule, you really can go after it. It's an 18 inch. Don't go after an abscess unless you know where the cavity is. Aspirate, ultrasound. Still can't find the cavity after all that. Do antibiotics on that in 4 hours because you want to be able to know what you're treating. Okay. If there's valvular heart disease or artificial prophylaxis, because you know what it is. And when you're giving the anesthesia, don't do it directly in the abscess cavity, right? That's not nice. So just pressurize it, all right? Don't think that you go all the way around the cavity. So now we're going to take a look at some of the, we want to find systemic disease based on rashes, right? So let's take a look. What are we looking at? How would we describe that? This is a new power, so don't make it really- So they're not flangeable. Petechiae. Maybe purpura. What might we be looking at, just looking at the rash? Doesn't have those target shapes that we saw with SJS, right? Say they're coming in with fever, severe headache, nausea, vomiting.
Meningitis.
Okay. So no, we're just looking at the rash. Give you more hints as we go along. Where is it and how's that
Rocky Mountains.
Almost the hand, what do you think?
Hand, foot, and mountains.
Hand, foot, and mouth. Okay.
Rocky
Also,
Mountains.
those are going to usually be vesicular, but I get it, sure.
Cabies.
So this young
Rocky Mountains.
person was out hiking recently. Headache, fever,
Rocky Mountain.
Rocky Mountain spot. So what do we treat it with?
Oxy.
Oxy. Yeah,
Nobody's good.
this is a little harder. I can show it. Yeah. Maybe thought sketch. Quite the mallet.
Okay. Erythema migrans.
What do we call that?
Erythema migrans.
Rash.
Erythema migrans.
Erythema migrans. Ready? Here's another one. Let's see if you get this one. Think we know what it is yet.
Is the palms involved or are his hands just red?
No, the palms are involved.
Okay.
Yeah. In fact, the fact that it's forming these confluent lines here, those are called pastille.
Scarlet fever.
But it looks like the bears are holding it.
Circummoral power.
Brad?
Wait, where are the lines from?
These confluence, you see how they almost form these like confluent lines of red? Which we thought that those actually skin rather than just the actual. Yeah.
I'm sorry, you were not showing it with a pointer.
Really?
Oh,
You see that?
yeah, I see
In
that.
fact, these lines are almost like, we look confluent. Yeah, like it looks like they're just coming together. They're just individual petechiae, they're coming together. Bigger. Great, so now it's gonna be a forever. Oh, I have an eraser, oh my gosh. Oh my gosh, I've been in the sun for a year and a half, and I've been using this pen for that reason, okay. Love discovering new things like the microphone. All right, ready?
Pemphigoid.
Vesicles, what are we thinking?
Bolus pemphigus.
What sort of varicose?
Oh. Probably
Chickenpox?
Shingles.
Shingles.
Oh, that's dewdrop on rosebud, right? Right, next you're gonna give it away. Right?
I like this. This is fun.
All right. So these are gonna be super highly contagious. Maybe it'll be a fever for 104 degrees, cough, or
Roseal.
coryza conjunctivitis.
Oh, measles.
Measles.
Wow, I literally wrote my.
Top
You had to give me the triple C's. Yeah, once I got the three C's.
Some rash,
Give me the three C's.
measles.
Funny. Oh.
Red bloodshot eyes, high fever more than 5 days.
Oh, yeah.
Strawberry tongue,
Yeah, I don't get this.
red swollen hands.
Except that it's the.
Alice, how do you treat it?
Yeah. I IVIG.
Aspirin, the only time you give aspirin to kids, right? Interestingly enough.
Yeah, there
everybody
was
has
another
also
one.
Have a lot of symptoms similar to outside.
Do you remember studying that? Yeah, I think it might be.
No, traumatic.
Inflammatory response.
Is it?
And then, just for fun, don't need to memorize this, but it is a really, you do need to know everything on there at some point. Right, you need to know the lupus rash, you need to know the post-exposure for AIDS, all that stuff, so you need to know that at some point.
Traumatic.
So that's just a good reference.
That you
Okay?
give aspirin? Yeah, that sounds
I
right.
was like, wait a minute.
I remember that
don't
there was
be so
something.
much sure. Whichever. That's basically how you do it. You also want to stabilize them in other ways, if they're hypotensive, maybe fluids, right? Based on the circulatory status or the toxin you want to treat. Hypoglycemia or inotropes. Certain microphilic cardiotoxicities, you need to actually give IV lipids. So one thing you need to know, first of all, is what was ingestion, how much ingestion, and when was the ingestion? Were there any symptoms at the scene? Was it accidental or intentional? Were there any home remedies attempted? The past medical or psychiatric history, and then call poison control to document consultants. Physical exam is going to not just be general, where you want to look for any odors, if there's signs of psychiatric illness or scalp hematoma. They smell like bitter almonds, to indicate cyanide. Derm, looking for bruising, cyanosis, flushing. Skin warm and moist, are there any boulage, barbiturates? The heart rate look like respiratory one, is there a murmur? If they're IV drug user. Murmur, hepatitis. Checking respiratory, etc. Are there any crepitations, fever from aspiration? And is there bronchuria or hypoxia, which could indicate or organophosphate? Checking the GI system, urinary system, salivating a bunch, urinary retention. And then, what are the fasciculations, how the reflexes, that is seizure, pupil size, reactivity, all those are very important. When it comes to trying to find because they don't come with the answers. They come looking a specific way, looking at the side, the way they're looking, how do I treat this? So first thing is always protect yourself first. Always protect yourself first. Make sure there's nothing that either the patient's safe to be around, or is there anything on him right now? Or dangerous. Stabilize them and then gather them the lab data. When it comes to treating toxins, we want to do one of two things. We want to decrease absorption or increase elimination. Main thing being get it out of the body as quickly as possible, or at least make it as not as harmful as possible. That's right, out. If there's an antidote which can help it, give an antidote. And then consider, will the person be able to go home back to 48 hours later for a follow-up, or do they need to get there? If it's in the eyes, do really good thorough irrigation. Like I said before, alcohol is much worse than acid. It actually causes deep tissue penetration. Ideally, you get the pH of the ice. GI decontamination is almost never done. Leaving it out of the GI system is almost never done. You never do acid. That's part of the action. Pick back up. Orogastric lavage. Here, where we just sort of like put it down and just rinse it out. It's again very rare, and this is a life-threatening issue. Whole bowel irrigation, or give them a lot of Miralax, probably have glycol, and make sure they don't aspirate, make sure cause obstruction by doing it. No real significant studies done. Some people suggest using it with asymptomatic body hackers, the type of drugs that are out. Eventually that bag is going to go down and you'll be by massive amount of care. So In that case, whole bowel irrigation. Works great. There's no studies. Decreased absorption, basically, activated charcoal can be very helpful in certain cases that have to be given more than 60 minutes after it's been ingested. And what it does is it actually attaches itself to the toxin and it adsorbs it. Doesn't absorb it, it adsorbs it, meaning the toxins stick to outside of the charcoal, and then as it passes through the system, it just holds on to it, so it gets out of the system. That's really helpful for things that are going to be in the system for a while, you know, the slow GI motility that could be anticoagulative. Or there's no antidote, or sustained release products that you go on of. You have to make sure that there's cooperative evidence. There's also certain medications we call the reservoir, which means water, the large solid penicillin. And you can mix it with ice cream or gastric tube and multi-dose, yes,
Is it less than 60 minutes or greater than 60 minutes?
greater than 60 minutes. Multi-dose activated charcoal is helpful for the sort of toxins that recirculate, like the intrahepatic, intraenteric recirculation within the system. That portion we're gonna have to talk about. Or anything that's like Philippines that are, again, not coming out of the system quickly. Carbamazepine, dapsone, so they might use multi-dose activated charcoal. More to leave the system quicker. And you can alkalize the urine, which is helpful for any acidotic growth. Tubules, maybe moderate severe salicylic toxicity, hemodialysis. It's not as effective if they're hypocalcemic. You can try urinary acidification if there's a weak base that was ingested, because risks of radical, etc. And then you can use extracorporeal removal. Fairly rare because it's very hard to have the type of toxin that works for it efficiently. Specifically, molecular weight, distribution, etc. There's three types: hemodialysis, receiving perfusion, and then there's a slower type of dialysis. And whether or not they go home is going to be based on your initial risk of assessment. Assuming they're not incredibly toxic after 6 hours, you feel comfortable sitting at home and it's not a modified extended release medication. They're okay to go home. Usually they'll be fine within 24 hours, so if they're part of the world. If there's an intentional deliberation. Questions on the general approach. In some cases, into some symptom portfolio. Botulism. Clostridium, botulinum. So these are going to be usually foods. Or an infant might get it, it might be in the wound, terrorists, basically spores in soil or dust, by the home candy, or 6-month-old, 7-month-old parents gave some money to. So this is a slide which pairs botulinum toxin versus tetanus. Remember, tetanus is going to cause a paralysis, but it causes a spastic type of paralysis. Botulinum is a flaccid. So if you see a descending symmetrical muscle weakness, you might have double blurred vision, the stage is arterial. The pupils are dilated and don't react to light, so it affects even the pupils as well. Babies will be floppy, weak, high force. What's another type of what's another neuromuscular disorder that can cause descending paralysis? City gravis. So they're the pupils won't be affected. DTRs will be normal or diminished. There's no sensory loss. It's fairly high mortality because of the respiratory filter. You need to be treated with IVIG as well. But now that we have good antitoxin, we can give better supportive care. Mortality rate is actually down from 60% to less than. So this is a table sort of helps break it down. GBS, memory, tick paralysis, all those are ascending, right? Myasthenia gravis, I think that is more of a generalized medicine. It's a generalized weakness, but importantly, there's no hyporeflexive myasthenia gravis. Except for the pupils are not affected. So now we're going to talk about a general set of symptoms that are called toxidromes. Toxidromes are specific toxins, toxin families tend to cause specific groups of symptoms. Really, the only way to get through a lot of these lectures is by getting pictures of it in your classes and sort out here. So working on that, I was pictures of what these toxidromes look like. Then we're going to have a lot of antidotes, unfortunately. That's really okay, so narcotic opioid toxin. So coma, respiratory depression, bradypnea, or apnea, slows down, pinpoint pupils. I mean, it could be the chemist that accidentally inhaled heroin. Yeah. And now they're taking treated naloxone. So Narcan and naloxone is very different to this point. I think it could be more. Some things didn't have it next to the AED because of how often it's occurring, right? Naloxone is a hand half that. Okay. And I have some charts for the just to help you compare the two. Where the graphic, all this is actually available in medicine. But this is an important point. Beware of polysubstance use. Just because someone is taking an opioid doesn't mean they're not also taking such a thing. Naloxone is only going to work in opioids. This are sympathomimetic toxicology. So these are the ones taking cocaine and amphetamine. So they're the total opposite of our opiates. They're hypertensive, tachycardia, hyperthermic, dilated, giant pupils, anxiety, equilibrium, and you have to make sure they don't have RAPTA. So what do you want to do? You want to treat them, sedate them, some benzos. Don't give them beta blockers, give them calcium channel. Because in certain dissections, you don't want to beta blockers, right? So you don't want to do that here either. Remember, someone with cocaine, who's a cocaine user, and they're coming in hypertensive, tachycardic, what else would be going on? Could be an MI, could be dissection, right? So again, taking a look at these clinical manifestations, mydriasis. So the way I remember meiosis versus mydriasis, mydriasis is mydriatic pupils are a larger word. Extra letter. And make sure there's nothing else going on. Rhabdo, renal failure, stroke. You may need a real workup, especially if they have cooking. Sedatives, hypnotics, so they're going to come in confused. We're talking benzos, we're talking about barbiturates, respiratory depression, hypotension, decreased temperature, hypothermic. Pupils could go either direction. Sometimes they may have boule if they're on barbiturates, they're burns, and you want to treat their airway, treat hypotension. Benzos specifically are going to be treated with Mazepam. And maybe if there's no risk of aspiration, it's activated charcoal. If they've altered mental status, don't forget to rule out other causes, glucose, etc. Hallucinogenics, psilocybin, LSD, PCP, marijuana, MDMA, ecstasy, right? Put them in a nice dark room. Close the door.
Right.
Use benzos, use alcohol, but that can actually lower the seizure threshold. Make sure there's nothing else involved. If they took hallucinogen, there might be some frustration. And I don't want your man, fuck. But in a nice dark room. That's, you know, right? But there can be complications. MDMA can cause hyponatremia from inappropriate ADH and hydration. And cannabis can cause vomiting. You'll hear them when you first come in during your morning shift. You'll hear them dry heaving away in your room, right? Because they say it's happens every time I smoke marijuana, I'm sitting up vomiting uncontrollably until I'm dry. So why do you keep smoking marijuana? Well, because I like it. Cyclical vomiting, diffuse abdominal pain, you get better with hot showers. So the best treatment, topical capsules can help. Maybe because they're not expensive. The topical capsules. Withdrawal is actually life-threatening. Already at that with people, which I agree on. Piloerection, Gerber syndrome. And the cows, opiate withdrawal scale, or CWA. Helps you as a way of scaling how into withdrawal when you're done. Believe it or not, the treatment for alcohol withdrawal is going to be benzos. Maybe find an opiate to replace any deficiencies. Benzos are basically the same thing. Alcohol. Cholinergic, so these are going to be like your farmer, someone who's been involved with pesticides of some sort. So these are, they're taking some sort of acetylcholinesterase inhibitors. Ate one of those mushrooms, right? So the acronym is dumbbells, diarrhea, urination, meiosis, bradycardia, bronchorrhea, emesis, lacrimation, lethargy, salivation, sweating. It's a common theme. They're leaking out of the head. Right? If there's a fluid, it's going to flow. Cholinergic. So ABCs, decontamination, atropine. But if it's organophosphate, if it's from an insecticide, we need to use pralidoxin. On the other end, think about that, right? So if that was a cholinergic toxin, what if someone is taking a lot of anticholinergic meds, like atropine, right? Or lots of Benadryl, histamines, cholinergic, or herbal remedies like gypsum, belladonna, right? So it's going to be the total opposite. Cholinergic toxin, they're leaking out of everything. They are going to be mad as a hatter, red as a beet, hot as heat, dry as a bone, blind as a bat, tachycardia, nausea, seizures. So again, supportive treatment as much as possible. Give them some physostigmine once you're certain it's anticholinergic. High risk of seizures. So you might need benzos that will do second seizure. Physostigmine only works if it's anticholinergic. Not anticholinergic toxicity. It's
Is that medicine the high risk of seizures or just the anticholinergic toxidrome?
It is. I believe it is both. I believe it's both. For
Okay.
sure the physostigmine.
Okay,
Sure the physostigmine, but, we also want to give them this list of compounds.
thanks.
Better than the physostigmine, they're worried about it. But they do say to treat mentos for agitation seizures, even without physostigmine. What about, everyone good on the toxicals? I know you don't have numbers yet, but you get the idea. So that was- Okay. Aspirin overdose. So there's something called oil of wintergreen. Wintergreen can have 7 grams of aspirin. So look, on Pepto extremely has aspirin in it. Significant aspirin overdose. It starts off with just basic respiratory alkalosis. But then it becomes an anion gap metabolic acidosis. It's a low bicarb, low PCO2, acidic pH. Acutely vomiting, hyperventilation, dehydration, even tinnitus. Even at therapeutic levels, tinnitus can be a side effect. Chronic, it can go either way. It might even be that's going to be altered metastasis, irritability, inflammation. So if you're coming in for an overdose, vital fluids, get fine completion up. Right? Treat any metabolic derangements, give them bicarb alkalis. That's going to be the GI decontamination. Maybe they're going to be dialysis. But that's aspirin. Everyone's aspirin. What about Tylenol? Tylenol's still really don't get beat up by Tylenol, right? So it's actually the most common cause of drug use. People take Tylenol when they're in pain. Vital tenors can't be that serious, right? The most common unintentional poisoning with a maximum dose is 3,900 milligrams, more than 325 milligrams, or 3 grams of the 500 milligrams, which means the maximum daily dose is 6 capsules. Otherwise, you're in toxicity. The P is going to be no more than 75 milligrams or 5 doses. What does it look like? I have tinnitus, dizziness, hallucinations, kind of tachypnea. You might have even signs of heart failure and signs of acidosis or alkalosis, metabolic acidosis, or respiratory system. Might even have hyperthyroidism. Right? So that first day or two that they're in overdose, they're having toxicity, not specific, they're not feeling so great, malaise, right? It's not wrong. I feel like they have a bit of a flu. It's going to take some day cool. Drop it and get out together. Yeah, go ahead, Tylenol. That's right. Some people reading Oxford bottles, right? So you're reading big, you're drinking big.
What are you doing your free time?
Take the Tylenol for your fever, but guess what? Now you're just making things worse. Because the initial issue is the fact you're they come in on day 2 or 3, you might actually see their LFTs have started to change. Might be some right pattern pain. At this stage, it's super easy to treat this. How can we treat it? I don't know. Right? No, they're going to keep taking it. Like coming in day 3, 4, or 5, with fulminant liver failure. Maybe it's ethnopathy, hypoglycemia, maybe even coma or death, but if they do survive, they can recover. Minimum toxic dose is 200 milligrams per pediatric or adult. About 10 grams, all that's going to be dependent on how many injections it takes. The antidote is acetylcysteine or N-acetylcysteine. Activated charcoal early, and if they're in moments, they might need dialysis. Mission ICU, Now, I mentioned this nomogram. The nomogram I'm about to show you is basically a chart that helps you to decide, do I need to start treating this patient for Tylenol or dose? It's somewhat limited, because only after an initial high dose of this acetaminophen, and it's within 4 to 24 hours of take. However, let's say someone took a tremendous amount of time, essentially on it. This line, the Matthew line, dotted line, was the original line which indicated if it was below the line, you don't treat it. If it was above the line, you do. We later drew this other line, which is about 25% lower, say you should start treating earlier. Basically, what you do is you take a look at the plasma concentration and connect it with how many hours it's been. So the plasma concentration is 30 micrograms per milliliter, and that's still at 24 hours post-injection. 20 hours post-injection. Don't expect anyone to memorize that, I just expect. And again, there's a chart to help decide how you want to do it. Run through a series of plans. Cyclic antidepressants. If I have this on site, overdosing on it. Within 6 hours of ingestion, might cause coma, arrhythmia, hypertension, respiratory seizures. So what is a cyclic antidepressant? Let's an example. Crippling. And it's a sodium channel blocker. So also keep in mind there might be some other infections reflecting manifestations. You want to check with electrolytes, check for any cardiac delays, make sure the time on check blood sugars, blood counts. Do GI decontamination, IV fluids, sodium bicarb help with any conduction abnormalities or hypotension that's not getting better with fluids. Don't give them physostigmine or clonazepam. So they took benzos, so now they're going to start inhibiting, right? Why? Because they might be having seizures. Having seizures with a antidepressant, I want to be able to give them benzo. If I'm giving clonazepam because they overdose as well, having issues, right? Because trying to treat their seizures with benzo, giving them clonazepam which will interact it. They might need fluids. If they're hypertensive, they might need more epi. If they're agitated, assure them. If there's any urinary retention after a G2, and if after 6 hours they're asymptomatic, home, not in medical ICU. What happens if they go into response? What do we give them? Magnesium. Excuse magnesium, right? SSRI or SNRI. So serotonin syndrome is SADA, iodism. It's rare to OD on them, but if they do, it could cause nausea, vomiting, sedation, tremors. Usually when the sign. Right. Serotonin syndrome, as you may remember, is a psychotic emergency. You want to get them an IV, cardiac rhythm, EKGs. And again, benzos, if they're having seizures. Synapse activated it's a helpful table just to sort of how can you differentiate between serotonin syndrome and leptic malignant syndrome. They all sort of look somewhat similar. MAOIs. Most people don't use them so much for depression. They are being put for Parkinson's. One pill. Very careful. It has delayed onset, 6 to 12 hours, maybe 24 hours. 6 hours. It does tend to have a low ratio of toxic to therapeutic dose. So that means they can be, if they take a little more than one therapeutic dose. So what does it look like? So we might have, there's no real typical presentation. Neurological agitation, might be tachycardic, mind reaces, or big pupils, hyperventilation, flushing, ping pong gaze, No known antidotes, just have to support them. Maybe activated charcoal dose to treat the hypertension, hyperthermia. But treated with benzos. Why? Because what's happening, the reason they're hypothermic is actually muscle corrected. So the antipyretic is not going to help you as much. You get this muscle contraction. Antipsychotics, which just cause an exaggerated effect of the pharmacologic activity, so maybe seen as suppression, lethargy. Might cause anticholinergic toxicity, which you remember tachycardia, dry as a bone, right? Decreased bowel sound. So they're actually going to be more agitated and you take more antipsychotics. Might even have orthoside. So, sometimes you have to be supportive. You have to make sure there's no torsades. If they're having altered mental status plus the rigidity plus fever plus that synthetic nervous system ability, now you have to be worried about ICU. Make sure to give them. In this case, rock would be better assessment. Lithium, acute, chronic, and acute non-chronic. So acute, they're going to have abdominal pain, non-chronic diarrhea, chronic toxicity, acute, on-chronic, chronic lithium toxicity, acute exacerbation, both neurotoxicity, which was cause diabetes insipidus. And if you suspect lithium levels, if they're on lithium meds, so just test are the lithium levels therapeutic or are they too high? They treat them, make sure you make the volume status in the side. Are they people to go home or admitted or intensive? Glycols, methanol, ethylene glycol. So these are going to be people who drink, I don't know, antifreeze, wood alcohol, paint stripper. They're going to look real altered. They're going to have anion gap with osmolar. Difference is osmolar gap, minute, specifically incorporates urea into it, anion gap. Methanol, they can come in as blindness, photophobia, blurred or snowflake vision, metabolic acidosis, suppression. It may be that they'll have glow in the dark urine, or what's in from the urine, so they can put into the antifreeze, but not every product has it, so we can't. Ethylene glycol will cause neurodepression followed by cardiopulmonary. So antifreeze blinds them, ethylene glycol. Isopropanol causes osmolar gap. Again, here's a formula, just osmolar gap, sodium, urea, it's rated the same. Osmolar, anion gap is, they call it anion gap. How do you treat it? Well, this is fun. As you get the ADCs under control, you give them ethanol. What's ethanol also known as? Alcohol. So what if they find someone down, drinking too much antifreeze at home, they don't have IV ethanol available, you give them oral ethanol. This is 80 proof liquor, or wild turkey, about 1.5 to 2 milliliters per kilogram. So PO, the loading dose, 0.25 milliliters per kilogram per hour. Okay, so just put that in context. Right? So that's going to be around for a 200-pound patient, going to be about 6 ounces or 4 shots. Wild turkey. Wild turkey, I think, is 80 proof.
Does it have to be wild?
Anything 80 proof.
Absolutely
And hit the liquor store.
You have to make sure you're giving them per hour 0.2 to 0.5 milliliters.
So now they're vomiting
So with the first
profusely.
line treatment
for 1
for
hour.
anti-congestion.
Alcohol. Yeah.
Give
Give them a shot.
What's that? 80 proof means it is 40% alcohol. Permissible IV fluids, so some wines just aren't gonna cut it. They go for hard. Omeprazole, IV fluids, dialysis, and repeat electrolytes. Caustic ingestion, so that's gonna cause functional as well as histologic damage. It can be intentional, it can be unintentional, we can check their airway, stay like incubate, protect yourself, make sure you don't get any caustic chemicals on you. Don't do a gastric decontamination. Why? Because you don't want to make that stuff move through the digestive system quicker. Right? You definitely don't want to do it lavage. Don't do emesis. It's caustic, right? Don't do it in G2. So it can just come back up through the nose, right? Correct any physiological derangements. They might need surgery. They might need TPN. If it's intentional, it's often associated with higher grade GI injury. Why is that? Drink more. So get lab studies, levels, ketones, check the serum osmolality, chest x-ray, endoscopy. That's usually the gold standard. And an EKG. It's going to be an anion gap acid lactate production. So a lot of tissue being shot. And the chest x-ray makes sure there's no peritoneal media air, then endoscopy.
We should say with extra
Somebody's trying to
with extra detergent flavor.
picture. So Tide Pods are much more concentrated, so it's gonna be a lot more. Tide two.
To be fair, they so look at them. Like they really
It's
do look
about
at
mud piles from ACLS, but if we had mud piles, sure, we could look at it. And it's-
Chef's
anything
kiss.
that causes anion gap acid. And some of these that we have seen today, PK we talked about. But ethylene glycol, methanol, given the boost. Salicylates, cyanide, and alcohol itself can cause it. Another mnemonic just for fun. These are going to be pills which are radio opaque. Check. Now, the reason why it's good to know what sort of pills we're looking at is because sometimes, unfortunately, a kid will get into a bottle of pills. You don't know which pills they got into or how many they felt. If it is a enteric-coated tablet, it's radio opaque. You do a quick X-ray to make this. But you need to get a really good history of what pills are on hand, what pills are possibly fell into. Like I said, if they need more MAOIs, you need to make sure that where that patient is going to be watched super carefully. Same thing with some diabetic patients. I'm not going to go into every single toxicity here, but at least prepared to know certain things. Now, let's say grandfather's watching the kid gets into the pill planner thing, right? So they don't know what pill it is. Every pill has on it a number and a letter, it has a very specific identifying mark, kind of on the ground, whatever it may be. You can actually Google, look up white oblong pill with this number and letter, right? And it'll tell you what medication. That's another safety. Big bottle of pills. No, I wasn't talking to you. You're good. And then just another quick chart. These are ones we talked about. Benzos, flumazenol, opiates. Anticholinergic to the segment. Benzos and caustic. Doxine. Methanol, ethanol, methazole, carbon monoxide. All that we've talked about. And the other ones will be cyanide, or nitrites, or lily kit. Nitrates, given that. Digoxin, that's going to be an easy one. Digibem. Digoxin, we can combine. Digoxin. Beta blocker toxicity, you want to get glucagon. Isoleucine, bicarb is like QRS. What can a YQRS turn into? Calcium channel blocker, giving calcium. Iron toxicity, deferoxamine. That's another one which might be a little easier, if you know, a little Latin. What is the Latin symbol for iron? Fe, so deferoxamine gets rid of them, right? So these are just little hints of all right? And chelation agents are just having. So if you're using deferoxamine, by the way, the urine will become almost this like red wine color until it's all out. It's really brown or rusty. But then once the urine gets back to a normal color, heparin, protein, coumadin, vitamin K, and you know, that's actually like really important because when we're dealing with bleeders, right, people with the coagulation cascade, you're going back to those hemorrhages that we were talking about before. So hematological emergencies, you want to find out, is it because they have a very high? If so, you want to provide it very high heparin. So that's going to be super helpful in manufacturers. There's isoniazid to give B6. What is isoniazid taken for? Then it's all based on medical consideration, psychosocial consideration. When in doubt. Now, so I had this fun idea, but it's people with religion. You don't think it because next time we have a guest lecture, it's going to be. But